Hi everyone, welcome to the AME office. I'm Dr. Dean Olson. I'm a senior AME and a HIMSS AME, and today I want to talk about obstructive sleep apnea, or OSA, and does your spouse sleep in the other room? Today is July 7th, 2024. My standard disclaimer, I'm speaking on behalf of myself and not on behalf of the FAA. The topics I want to talk about today regarding OSA are: who should worry about it? What is it? What are the effects if you have it? How do you test for it? How is it treated? What aeromedical risk level is it? And how do you proceed if you've been diagnosed with OSA? So, who should worry about OSA? In general, about 10 to 15% of females and 20 to 30% of males will have OSA. Patients with certain conditions have an increased likelihood of OSA. This includes morbid obesity. About 70% of those patients will have OSA. Type 2 diabetes, again about 70%. Hypertension, 40%. Patients who have morning headaches, about 30%. And veterans, about 20% will have OSA. If you have certain symptoms, you should worry about possibly having OSA. These include snoring, so does your spouse sleep in a separate room because of your snoring? Difficulty concentrating, thinking, or remembering. Daytime sleepiness, so fatigue and the need to take frequent naps. Are you having daytime headaches? Are you irritable much of the time or have mood changes? Do you have a short attention span? And if you're experiencing impotence, you might have OSA. Now, there's a set of questions that have been clinically proven to be significant when assessing the possibility of OSA. There's a total of 8, so let's look at these, and I would suggest you keep account of how many times you answered yes to these questions. So here we go. Number 1, it's related to snoring. Do you snore louder than talking or loud enough to be heard through closed doors? Number 2, focused on being tired. Do you often feel tired, fatigued, or sleepy during the daytime? Number 3 is observed. Has anyone observed you to stop breathing during your sleep? Number 4 is blood pressure. Are you being treated for high blood pressure, or do you have it? The 5th is body mass index, or is your body mass index greater than 35? If you're curious, I've included a link to a BMI chart in the information section for this video. Number 6 is age. Are you 50 years old or older? Number 7 is neck circumference. Is your neck circumference greater than 40 centimeters? And finally, number 8 is gender. Are you male? If you've answered yes to 3 or more of these questions, then your risk for sleep apnea is high. And if you answer yes to 2 or less, then your risk for sleep apnea is low. If you found that your risk level is high, you should very much consider being tested for sleep apnea. Okay, so what is sleep apnea? First, I want to define 2 terms because it's important when we consider testing for sleep apnea. The first term is apnea, which is defined as a lack of breathing. The second term is hypopnea, which means having a decreased rate or depth of breathing. So obstructive sleep apnea is a breathing disorder that causes repeated pauses in breathing during your sleep, which causes your breathing to stop and start throughout the night. It's caused by a narrowing of the upper airway, usually due to an excess of tissue in the upper airway and tongue. And this is generally but not always associated with being overweight. When a person gains adipose or fat tissue, that tissue will accumulate all over their body, including around their airways, their soft palate, and their tongue. Now, all of these sites of accumulation will help to cause a narrowing of the airway. As you can see in this diagram, when a person lies down to sleep at night, gravity can pull the tongue and tissue down, causing a partial or complete blockage of the airway. As you would expect, this impedes the airflow to the lungs. So, what are the effects? Well, the immediate effects are that you're going to have multiple arousals during sleep, and usually this is unrecognized and can occur hundreds of times at night. Obviously, this leads to poor rest and then will result in people being sleepy and tired during the daytime and having daytime fatigue. The other thing that it can result in is having headaches upon awakening or throughout the day. Now, neither of these are good for the flight environment. The long-term effects over time have to do with repetitive nights of OSA and not getting enough oxygen to your organs. Obviously, this is not a good thing. If we consider the brain, this can lead to memory loss and stroke. If a person is limiting oxygen to the heart and the vasculature, this can lead to lung hypertension, arrhythmias, or heart attack, and systemic hypertension. OSA can also contribute to diabetes and obesity. Now I want to talk just a little bit about lung hypertension because the lungs are pretty cool, but it's not just the lungs that are affected. There's an upstream effect from having lung hypertension. The lungs are very efficient, and if there's an area of the lung that is not being oxygenated by breathing, then the blood vessels in that portion of the lung will constrict. And that causes blood that would normally go to that part of the lung to be shunted to the other portions of the lungs that are being oxygenated. You might see this in a situation where someone has pneumonia in one part of their lung. Now, in the case of upper airway obstruction, as in obstructive sleep apnea, what's happening is we're not oxygenating all of the lung tissue. When this happens, all of the vasculature in the lungs will constrict. Now that's a big deal to the right side of the heart because of the right side of the heart is a low pressure system. And there's not much distance that the right heart has to pump to get blood to the lungs. And there's a lot of vasculature in the lungs that all contributes to this being a low pressure system. When that happens, there's a back pressure that's being applied to the right side of the heart. And that can eventually fail and the person can go into heart failure. And this can lead to a backup of fluid in the rest of your body. And people many times can have swelling of the arms and legs or edema, as well as shortness of breath and reduced exercise capacity. So if you think you might have OSA, you should get tested. So how do we test for sleep apnea? Basically, this is done by doing a sleep study. You should talk to your primary care doctor about who to see, or you should seek out a sleep specialist in your area. Many ear, nose, and throat physicians will provide testing and treatment. Now, the FAA prefers one of two types of sleep tests. The first is an in-office or in the sleep lab type of test, which they refer to as a type 1 test, or the other is a 7-channel home sleep test or a type 2 test. The important part is that the test must be interpreted by a sleep medicine specialist, and it must include a diagnosis and any recommendations for treatment. When a sleep study is performed, the main indices that the FAA is going to look at is the Apnea-Hypopnea Index, or AHI. This is a count of how many apnea or hypopnea events occur per hour. Based on this count, patients can be categorized as having mild, moderate, or severe OSA. The mild category is 5 to 15 events per hour, the moderate category is 16 to 30, and the severe category is 31 or more. So if you get a sleep study and you're found to have OSA, the good news is that it's highly treatable and there are multiple options. First and foremost is behavioral changes. If you're someone who's overweight and you have the ability to lose 10, 15, or 20 or more pounds, it's possible that your OSA could go away. Next is dental appliances. In general, there's two types of dental appliances, ones that don't collect data and ones that do collect data. Basically, dental devices reposition your jaw to help hold your tissues up and keep the airway open. Next is a continuous positive airway pressure machine, or CPAP. This device creates a positive pressure in your airway, which helps keep the airway open and doesn't allow tissue to collapse. This is similar to blowing up a balloon. And this is the most common form of treatment for OSA. And finally, there are surgical methods. And most of these alter the structure of the airway, whether it's holding up certain tissues by inserting supports or removing tissue to make a bigger opening, so to speak. One surgical option also includes the Inspire device. And as you can see in this diagram, this is an implanted device under the skin that monitors your breathing. It works by stimulating the airway muscles with electrical pulses to keep the tongue out of the airway. Generally, this is suitable for moderate to severe OSA or for cases that have not responded to other treatments. But in general, non-surgical options should be tried first. When we look at aeromedical risk level classification, again, this is my risk level classification, not the FAA's, you can see that OSA falls at level 2, which is an AASI category. AASI stands for AME-assisted special issuance, and this is the lowest level of special issuance. In general, AASI categories require an initial approval from the FAA with the issuance of a special issuance authorization letter, and then subsequent issuances of a medical certificate can be performed by the AME. In this category, OSA is a little bit special because the AME is allowed by the FAA to issue the initial certificate if the pilot's condition meets all the appropriate criteria and they pass their flight physical. So, if you have been diagnosed with OSA, how do you proceed? First and foremost, you should start treatment as soon as possible. Because of your diagnosis, according to the FAA, you are not allowed to exercise your medical certificate privileges, meaning you shouldn't be flying, until you provide information to the FAA or to your AME. So what information should you provide? There are 3 or 4 documents depending on your treatment. The first is a signed FAA compliance with treatment form. This is a form that you fill out attesting to your compliance with treatment for OSA. I have a link to the form in the information section for this video. The second document is the results and interpretive report of your most recent sleep study. The third document is a current detailed clinical progress note from your treating physician addressing your compliance, your tolerance of treatment, and resolution of your OSA symptoms. The FAA provides an initial certification provider worksheet that your doctor can fill out instead of providing a progress note. And if you are going down this pathway, I do recommend that you use the worksheet. I've included a link in the information section for this video for the initial certification worksheet. If you've had surgery, you'll need a statement from your treating provider that you have a continued absence of OSA symptoms. If your treatment is a dental device without data recording, the FAA will want a statement from your treating provider that your treatment is effective. The final item, item 4, depends on your treatment type. If you're using a data collecting dental device or CPAP machine, you'll need to provide a report from the device for all of the time of use thus far. In particular, looking at CPAP devices, the FAA has several parameters that they want you to meet for certification. This includes using the device at minimum 75% of your sleep periods, and that the average sleep time is 6 hours or more. They also want your AHI to be less than 5. So if you present this material at your next flight physical, the AME has permission from the FAA to issue a certificate as long as you pass the physical and your OSA is effectively treated. So a few notes. First, a note on allergies in OSA. I've had several pilots with OSA who are not obese and carry no significant risk factors, but who have known seasonal allergies. If you fall into this category, you should discuss treatment with your provider concerning nasal steroid sprays, okay? This can reduce the swelling of the nasal tissue and may reduce or eliminate your OSA. And then a final note, the FAA may be changing the requirements for OSA in the future. They recently have mentioned this in one of their meetings. It may affect only a portion of the pilot population with OSA, and likely it will drop the requirements to a CACI criteria condition, meaning only the AME would need to be involved to make all the certification decisions, and it would not require special issuance. So keep your eyes peeled for future developments. Well, that's it for obstructive sleep apnea. Thanks for joining me. If you would like to, please subscribe, and as always, please share this YouTube channel with your colleagues so they can join in. If you have any questions or would like to suggest a topic of discussion, please leave a comment. Thanks, have a great day, and I'll see you next time in the AME office.